Well, hello, friends. Welcome back to this episode of Test Those Breasts. I am your host, Jamie Vaughn, and I am super excited to have my guest, Dr. Tiffany Troso-Sandoval, on my show again. Some of you may remember that I interviewed her quite a few months ago, and we've just kept in contact because, we like to collaborate with each other, and, I learn a lot from her. And so I am so excited to introduce Dr. Troso-Sandoval, and she is a highly esteemed medical oncologist with over 25 years of expertise in treating women's cancers. Throughout her career at Memorial Sloan Kettering, she published over 20 research papers in prestigious medical journals and authored a specialized publication focused on providing care for elderly patients with ovarian cancer. Dr. Troso is now expanding her reach outside of the medical clinic to help women across the country through her company, Winning the Cancer Journey. She is now utilizing her skills and expertise to help others through public speaking, webinars, virtual medical consultations, and workshops. After caring for thousands of patients with breast and gynecological cancer, Dr. Troso has a passion to improve the outcome and quality of life for cancer patients by providing education, guidance, and development of a winning mindset. Her upcoming book, Winning the Cancer Journey, will be published in early 2025, and she is also working on the development of an online interactive educational platform for cancer patients and their caregivers. Hello, Dr. Troso. How are you? How are you doing?
Wow, that was a mouthful, huh?
I know. You have so much to offer. I love it. I love it.
Thank you so much for having me. I'm so excited to be able to speak to your audience. This is really exciting. Thank you.
Me too. And I just always love to follow you. And I've had other people follow you on our, especially Facebook group and stuff like that. And you have just provided such needed information and education for our cancer community. So we're lucky to have you. And I'm excited because you just went to the breast cancer symposium, and gosh darn it, I didn't go, and I should have gone.
Next year.
I was
We're going
planning
together
on
next
it.
year.
Yes, we are. And I was planning on it. And just things got in the way and stuff. So next year for sure. But you learned some things there that are just a mind blow, and of how people are going to be cared for coming into the near future. And I just want you to share what it is that you learned. I know there's a ton.
There's so much.
I know
Crazy.
maybe you can pick some of your top
Sure.
things that you learned that you can share with our audience.
I may have to come back another time because I've got so many things, Jamie.
Totally fine with that. Anytime, really.
Sure. Well, thank you again. I'm thrilled to talk about all these things. So I'm going to try to give some broad strokes. So, if you follow me on Instagram or even Facebook, LinkedIn, we'll give you all those addresses at the end, because I do post a lot of detailed information about some of these studies that I'm going to be going over. But just for the purpose of an overview, I don't want to sort of get too much into the weeds. So I'll probably be talking more on, a little more topically on some of these things. So some of the biggest things that I found at San Antonio, well, my number one favorite thing, you're going to like this, Jamie, is I was blown away by how much interaction and support and utility that all of the patient advocates brought to San Antonio Breast Cancer Symposium. It was unprecedented, in my opinion, and so needed. So what do I mean? So they had patient advocates, and these would be women that had cancer or have cancer. And there would be some major educational platform. One of them I'll talk about is about ctDNA. And they would have the patients up there on the stadium, on the platform, with the physicians and the researchers, and they would discuss this topic intellectually. They would discuss some of the research, and then they would turn to the patient advocate, and the patient advocate would give her opinion of that drug and things that were discussed in the platform. And it was amazing because, a lot of times when doctors discuss different things, what we consider to be well tolerated is not exactly so well tolerated for the patient. So, for example, there was one woman that was up on the platform during one of the review sessions about some of the bigger topics. And they were talking about patients that take CDK4/6 inhibitors like palbociclib. And the patient, they were discussing, well, this is a very important study because we know that palbociclib is so well tolerated by the patients and it shows such an advantage for them to be taking it. And the patient advocate was like, yeah, define well tolerated, because 4 to 6 loose bowel movements a day is not exactly well tolerated. So doctors speak well tolerated. That means, well, okay, they are still living their lives. They're not in the hospital. They're not, you know what I'm saying? Versus, what in reality is really well tolerated. It's just a good reality check for physicians to sort of take it back down to the real level of the patients and how they're experiencing the things that we're discussing. It was phenomenal. So patient advocacy was huge.
Yeah, because like quality of life is so important, and it is important for them to understand where the patient is coming from. So I love it. I love that was presented in that way.
So there was actually another study, not specifically about advocacy, but bringing on the fact that, having what the patients have to say makes a difference in terms of quality of life. There was a study that they produced, it's called the PROB study, in which they looked at women that had metastatic breast cancer. And they had an online sort of AI-driven check-in. So they found that the patients that had, regular every 3-month follow-ups with their physicians versus this online reporting platform where they would be reporting their different symptoms on an almost daily basis. These patients that had that reporting system not only had better quality of life, they lived longer.
Oh,
I mean, that's unbelievable. Now, if you ask me, it sounds very, obviously, they had better quality of life because somebody was actually paying attention to them on a day-to-day basis. But the fact that it also translated into the women living longer, I think that's, it's really groundbreaking. And it makes you wonder, like, well, why don't we have these systems all around the country? Everybody should have this ability. So hopefully there'll be some, movement in computerized AI interactions with patients in the near future. Let's see, what else should we talk about? The other big theme I saw was what we call de-escalation. And what I mean by that is that instead of giving everybody the whole kitchen sink, we try to bring it back and see, well, what's really necessary here? So one of the very exciting studies that they discussed was about patients that had low risk DCIS, ductal carcinoma in situ. And that's like the pre-malignancy. Right now, the standard of care pretty much across the board is to remove the tumor or the area of the pre-malignancy. That's called a lumpectomy. Some patients have a mastectomy for other reasons. You don't need to have a mastectomy for DCIS. That might be a personal choice or because of genetics. But with the lumpectomy, then they would get radiation therapy to that area. And then they'd often be offered tamoxifen for 5 years. All of that for this in situ preventative type of thing that nobody dies from DCIS. It's really a matter of trying to prevent it from, progressing into an invasive cancer that somebody could develop. So they looked at this study and certain criteria were met where the tumor was estrogen receptor positive, it was low grade, it wasn't that aggressive. And they actually looked at observation versus standard surgery with radiation. And patients were offered in both groups actually to take tamoxifen if they chose to. There was about 8% of the patients that were randomized or sent over to the group that was supposed to be just observation, that they didn't feel comfortable with that and that they wanted to be in the other group. And so you were able to switch the groups. But at any rate, they actually showed that after 2 years, they're still following these, but after 2 years, there wasn't any substantial difference in terms of recurrence or new breast cancers being formed, even if they didn't take it out. So that's pretty groundbreaking in terms of de-escalation, right? I mean, think about all these patients that had DCIS that have the lumpectomy and the radiation and the tamoxifen. We're treating it almost like it's a stage 1 breast cancer, right?
So are you saying that it was kind of this idea of over treating things that were not necessary?
That's what I mean by just de-escalation. Yeah. Wow. So we're sort of peeling back. How much do we really have to do? There was another study on women with breast cancer, and this was sort of like an upfront surgery. So Dr. Monica Morrow, who is the head of breast cancer surgery at Sloan Kettering, presented this data looking at women who had, again, like what appeared to be a low stage estrogen receptor positive breast cancer. And they were looking at whether or not it made any difference in the long run. They had the axillary dissection done. And so this is groundbreaking, right? So how many women have had axillary lymph node dissections or even sentinel lymph nodes done where, you know, they've had problems or complications from having somebody in that axilla? So in the study, they showed that, again, no significant increased risk of metastatic disease if you don't take those lymph nodes out. But it's, you know, it's a little provocative to doing that because as a medical oncologist, I need to know what's in those lymph nodes because that helps me decide what I'm going to do. So it's not considered, you know, practice changing yet. We're still just discussing it, but it was very interesting information that in terms of how well the patient does in the long run, as long as it's a low risk, you know, seemingly early stage cancer, they don't even have to take the lymph nodes out.
Yeah,
Who knew?
because I remember they took 3 out on the breast cancer side and 1 out on the other side, specifically just to make sure that nothing was there. Yeah.
Yeah. So I thought that was pretty interesting.
Very.
So let's see, what other kind of stuff? Do you have any specific things you want me to talk about? Do you want me to talk more about metastatic cancer, early cancer,
Let's talk
diagnosis?
metastatic cancer. I've been talking to a lot of people who are dealing with metastatic cancer now. So yeah, let's talk about that.
Okay, let me pull up a couple of studies. Now, as I mentioned to you before we got online, I'm referring to a document where I sort of made an outline of some of the different talks that I want to discuss with you.
Okay.
And I am going to clean it up and make it patient user friendly. And I'm going to give that to you after the production, and so that you could put that down in the notes so that people can access that document, so you can refer back to it.
Okay.
So at any rate, one of the very exciting studies was called the PADMA study. So first I have to back up because I don't know what your audience knows. So do you talk about CDK4/6 inhibitors often?
Never.
Gotcha.
Never.
Okay.
I've never even heard of that.
Really? Okay. All right. So that's really important. So in estrogen positive metastatic breast cancer, the standard of care, it kind of goes back and forth, is to use upfront an aromatase inhibitor, right? Or if a patient's not in menopause, they have to get a Lupron or something to make them chemically in menopause. And then an aromatase inhibitor like a Arimidex or a letrozole and estrozole, right? And then we add another drug to that called CDK4/6 inhibitors. And that second drug, which I was referring to before, that can cause the diarrhea, right? Actually substantially improves response. So it substantially improves the cancer responding. And basically it's because with an estrogen receptor positive cancer, you're giving 2 different drugs and it's kind of killing it in 2 different ways, right? So it's hitting the pathway. So the way a cancer would grow is, say that the receptor, which is like a little antenna on the outside of the cancer cell, right? And it pulls some estrogen from the body. And that estrogen, once it binds to the receptor, causes the cell to get a signal that it can grow and spread and survive. Right? And so by the different ways of getting rid of estrogen, one of which is the aromatase inhibitors, aromatase inhibitors prevent estrogen being made in your body outside of the ovaries when you're in menopause.
Interesting.
So premenopausal women, like 98% of the estrogen in your body comes from the ovaries, right? And when you're in menopause and the ovaries are either not there because they were removed, they were shut down chemically by a shot of Lupron, or they went into menopause and they stopped working because of chemotherapy, or you just reached the age where it just stopped working, right? So there's a couple different ways you hit menopause. At that point, that 98% of estrogen isn't coming from the ovaries anymore, but there's still a little bit of estrogen that's being made in other parts of your body.
Okay.
And the estrogen in that situation is converted from other hormones like testosterone that our bodies make, and it's chemically converted into estrogen. And that conversion is created by an enzyme called aromatase. So a chemical reaction, taking one hormone, switching it into estrogen. Now all of a sudden there's some estrogen floating around in your body when you're in menopause, and it's caused by this enzyme called aromatase.
Okay.
So an aromatase inhibitor blocks that enzyme and prevents that conversion. Does that make sense?
Yes, it does. Well, I'm picturing it in my head because I wondered where the estrogen comes from after you don't have ovaries. Like I don't have, mine was ERPR negative anyway, but I had my ovaries removed during my first or second, it was my second surgery. So I always wondered, where is that
Where the
estrogen
hell is that
coming
estrogen
from?
coming from? Right, sure. So another concept I think that your patient, everybody should understand, is what an ESR1 mutation is. So again, going back to that whole, I wish I had a diagram to draw. Going back to a cell, and there's that receptor antenna that's looking for the estrogen in the blood floating by. Sometimes this, after you've deprived it from the estrogen by taking that aromatase inhibitor, so now there's no estrogen and the cell's like looking for it, right? So by survival of the fittest, one of these cells, when they're duplicating themselves, might make a mistake. And one of them might have a mistake where that estrogen receptor is broken.
Oh,
I didn't mean to give you the finger. Broken.
love it.
Broken, right? And it's broken in like that it's turned on. So it doesn't care anymore if there's estrogen in the body. It thinks that there is, and it's still turned on. It's sort of like the gas pedal gets broken and stuck on, right?
Okay.
And so now the cell doesn't care if it has estrogen, and it's just growing and spreading and what have you. So patients that are taking aromatase inhibitors can become resistant to them by this mechanism.
Okay.
And that thing that happens is called ESR1. ESR1.
Yes.
Estrogen receptor 1. Anyway. And so there are drugs that we use in that situation that go after the estrogen receptor that's broken, goes after it here, and makes the cancer cell just kill off, get rid of the estrogen receptor. So now it gets rid of that broken receptor. And those are called SERDs, selective estrogen receptor degraders. Okay. So there's 3 different ways that we kill estrogen receptor positive cancers. The other one is called a SERM, selective estrogen receptor modulator, and that's tamoxifen or Evista. So tamoxifen, again, going back to our receptor, right? Looking for estrogen in the blood, premenopausal or postmenopausal, doesn't matter. There can be estrogen in the blood. But tamoxifen looks just like estrogen, and it binds into that receptor, okay? And it blocks the receptor. So the estrogen's still floating around, and it can't get to it because the tamoxifen blocks all the
blocking
receptors.
it. Okay.
So that's a SERM. A SERD is where it just degrades or gets rid of the receptors altogether. And then the aromatase inhibitors are the ones that prevent the creation of estrogen from other hormones. So if you understand all that, you can understand a lot of the treatments that go into estrogen positive breast cancers.
Okay. So I'm trying to remember what the chemo, I had 2 chemos and mine was ERPR negative. So what?
Wait, did you have HER2? What was your HER2? Okay,
I did.
So you were ER negative, PR negative, HER2 positive.
Yes.
Correct? Okay. So Herceptin is an antibody against HER2.
Okay.
So
that was the first one.
Here are the receptors again, right? So in the receptors situation with HER2, HER2 is normally present on all of the cells, but there's only supposed to be 2 copies of it. So there are only supposed to be 2 genes in each cell that make HER2. In a HER2 positive cancer, those genes get duplicated. And so that's why you get a HER2 positive score. And that means that, say, there's 6 genes that are making the HER2 receptor. Now, all of a sudden, instead of, 2 receptors, there's like 6 of them on the outside. And so those cells are like revved up because they're getting growth factors in the blood, binding to those receptors and signaling the cell to grow and spread and live. So Herceptin and pertuzumab are the antibodies. Perjeta is the other name for pertuzumab.
Perjeta, yeah.
Perjeta,
Okay.
Herceptin and Perjeta are antibodies that bind to those HER2 receptors and help block them from signaling.
Okay, so question.
Yeah.
I had 4 things that were infused in me every time I went in. One was the Herceptin and Perjeta, and the other one's
Yep.
Perjeta. The
Yep.
2 chemos, though,
Yep.
there were 2 chemos as well, and I don't remember.
It's probably Taxotere and Cytoxan.
Maybe Taxotere sounds familiar.
Mm-hmm.
I didn't know what it was. I know that it was supposed to help shrink the tumor, which it did.
Mm-hmm.
But those 2, I'm just curious why
Mm-hmm.
those ones are chosen over other ones. I mean, I know that there's
Yeah.
just different kinds.
There are other regimens that where I came from at Sonketa, and we didn't use that regimen quite as much. If a patient was going to get full chemotherapy because you had positive lymph nodes, for example, we were using adriamycin and
Okay.
Cytoxan, which is AC. Patients would get 4 cycles of that. And then we would usually use weekly Taxol or every 2-week Taxol, depends. And Taxol, which is a cousin of Taxotere, would be given once a week. And then Herceptin and Perjeta would be given every 3 weeks.
Okay. So I got the 2 chemos and the 2 meds every 3 weeks together.
Correct.
Okay.
It's just a different regimen. And to be honest with you, you're on the West Coast or close to the West Coast, and I'm on the East Coast. And, a lot of these regimens have been compared and, what have you. And there's usually more of like an institutional bias from where you're being treated. And it might depend on which clinical trials your institution was actually, working on before these drugs were approved. But what's actually interesting from San Antonio is that they looked at a clinical trial in which patients with HER2, let me just pull this one up for you, where patients with HER2 positive breast cancers actually didn't necessarily have to get chemo at all. So isn't that cool? So there was a trial where they looked at using an anti-HER2 medication in combination with something else, and they were actually even able to not need chemotherapy in some certain circumstances.
Wow.
There was also
lucky them.
Yeah. Well, they still were. So here's another study. Okay, so there's something called an ADC. You know what I think, Jamie? I think we're probably better off doing like just general topics, and maybe I'll come back and go over some of the trials, or I'll just post them, because I feel like we need to kind of make sure that everybody's on the same playing field of understanding. So an ADC is an antibody drug conjugate. And what that is, that's super cool. So we already talked about the receptors, right? The receptor on the outside of the cell. And there's all different kinds of receptors. And so an ADC is a drug where they find a receptor that's frequently found on all breast cancer cells, or on most breast cancer cells. And it can be the HER2. There are HER2 ADCs. And they take that. So it's something that binds to a receptor, like in this manner, is called an antibody. So they take the antibody to HER2, and then they link it to a chemotherapy agent that is not activated until it's gotten into the cell. So again, it's like a smart bomb, sometimes people will call it. And basically, you have the antibody, and it finds a cancer cell, and linked to it here is a chemotherapy. So once it binds to the cell by the receptor, it gets taken into the cell, and then the chemotherapy gets released, and it kills the cell from the inside out. Smart bomb.
Very interesting.
Isn't that cool? So
yeah,
tons of these are in development right now. And I'm sure some of your patients that may have more advanced breast cancer may have heard of some of these. So for example, in HER2, I don't know if anybody's heard of that one. TDXT is what it's called. And that's a Herceptin-based drug. And there are others that they found that are supposed to bind one of the, not HER2, but a different HER receptor. And they are finding that cancer cells that even aren't considered HER2 positive, so you say that your cancer cell was HER2 positive, that's why you got Herceptin and Perjeta. They're finding that patients' cancers that are HER2 low, meaning they didn't have, instead of having 8 receptors on the outside, maybe they only had 2, maybe they had 3, something. So it's still considered like pretty low, that some of these ADCs that bind to HER2 still work.
Hmm.
So now we've got these smart bombs that are binding to cancer cells, even, sort of very specifically. And they're showing that some of these ADCs work even better than chemo itself.
Wow.
Yep. And much
Very,
better
very
tolerated,
interesting.
much,
So
much better tolerated.
when you were practicing, were you very upfront and able, or did you find that you explained what patients were getting and why? Because
100%.
I was never told any of this.
Yeah.
It was like, we're doing this, this, and this. And I had no idea why. Like, here's one of the things, and I think I've asked you this before. At the beginning of mine, I was told that I was going to go through the chemo first and then have surgery. And all I ever heard was from all these other people where they got breast cancer, had surgery, and then chemo. Why is there a difference between when you have surgery and chemo, like, and some are just completely opposite? Those were never actually, that's not true. She did explain to me that part of it was for efficacy. She wanted to see if that chemo would work on me. Wanted to see whether the tumor would shrink first. So she
Yeah.
actually did explain that part to me.
Mm-hmm.
Why doesn't everyone do that?
Well, first, let me answer that second part. So,
Okay.
the reason all this stuff flows right off my tongue is because this is how I spoke to my patients all the time. And I pride myself in my ability to explain these things. And I usually, unfortunately, I didn't set up like for this today, but I often will make drawings, and my patients will go home with like pages of my drawings and my illustrations of why things work. And it's a little easier to draw things out and explain at the same time. But and that's exactly what the basis of my entire company is. Winning the cancer journey means that you are going to get the best outcome you possibly can with your breast cancer treatment.
Okay.
In other words, I want you to get through this with confidence, clarity about what's going on and why you're doing all these things, and also with a sense of community. In other words, I want you to be able to be confident enough to speak to your physician and ask the right questions because you understand. And also, I want you to be able to partner with your physician and your whole care team so that you are part of the decision process. And I think all of that boils down to knowledge is power, education. And so, what we've been talking about tonight is standard fare for how I help patients these days, and always actually. So, going back specifically to your question about it's really what you're asking me is why do some patients get neoadjuvant chemotherapy, meaning before the surgery. Yep. So you've already mentioned one of the reasons. So if you can give somebody chemotherapy and actually can still feel the tumor, you can check it every week or two and make sure that it's shrinking, right? And so you have sort of a litmus test is how sensitive the cancer is to the chemotherapy. So that's one benefit, but that's not usually why we do it. That's sort of like an added benefit.
Okay.
We usually do it for two main reasons. One, the most common reason is because the tumor is too big and the patient wants a lumpectomy, for example. And so we need to shrink the tumor down so it's more contained so that they can do a clean, easy lumpectomy, remove the tumor. We also have to sometimes we have to downstage the axilla. So if we see on the MRI, for example, that there are 4 positive lymph nodes, we'll give chemotherapy first to try to kill off most of the cancer cells in those lymph nodes so that we don't have to take 20 lymph nodes out afterwards, because that would cause more problems later on. So downsizing the tumor is probably the main reason.
Okay.
And the two types of cancers that we usually do that in, I mean, we could do it in all 3 types, but the main 2 that we do it in are either triple negatives or HER2 positive breast cancer.
Okay.
Because those are usually, exactly. And those are usually the cancers that are dividing more rapidly than an ER positive breast cancer. But let me just tell you the third one. So the third reason is because of these ones that are dividing more rapidly, like a triple negative or like a HER2 cancer, we want to make sure that we get the chemo in there to control the cancer, to make sure it doesn't spread anywhere else before you get to surgery. So we're killing off micrometastatic disease before it gets a chance. So I'm sure you had a CT scan or a PET scan before you started chemotherapy to make sure that it hadn't already spread, at least to what was visible to our eyes on radiology. And then because you had an aggressive types of cancer with the HER2 and your tumor you started to say was 5 centimeters, they wanted to shrink it down and get rid of any microscopic cancer cells that might have escaped out into the body before you went to surgery.
Totally. And what I wanted to know was, I don't even know what is considered to be big. Is 5
Mm-hmm.
centimeters considered to be big?
Yeah.
Because
Yeah.
I mean, I felt it. Yeah.
Yeah. That's a sizable tumor. Yeah.
I had a mammogram and an ultrasound a little less than a year prior to my
Mm-hmm.
diagnosis. They saw nothing.
Mm-hmm.
So that must have started growing from that point forward and pretty fast.
Yep.
Just
Yeah.
is very fascinating.
One of the things that people can look for in terms of the growth rate of the cancer cell, if you looked at your pathology report, is the Ki-67. Ki-67. And that is a measure of the growth rate of a cancer cell. So something like an acute leukemia that grows really, really fast has a Ki-67 of like 90%, 95%. So that's really fast. Whereas something that's like a low grade tumor, meaning like less aggressive looking, might have a Ki-67 of 15 or
So if
20.
I go back to my pathology from my
Mm-hmm.
diagnosis,
Mm-hmm.
I can see what that level is. And
Correct.
then I can kind of think about how fast that was growing that
Correct.
whole year.
Yep.
Interesting.
Yep.
Hmm.
Yep. So oftentimes,
Fascinating.
though, the patients usually get chemo before surgery. Neoadjuvant is the word again. And then they have surgery. And then usually we'll get more chemo afterwards as well. And then you probably got maintenance Herceptin and Perjeta for a year, right?
The rest of the
Yeah.
year. Yeah.
Yeah, exactly. Mm-hmm.
Yep.
Yeah.
Yeah, and then of course I always tell people it's like, oh, when you get breast cancer or any kind of cancer for that matter, there's
Mm-hmm.
always something else that's going to happen. Like for me, I developed a rare anemia, and because of the thymoma tumor that they found,
Right.
and it was putting off antibodies and it was
Right.
attacking my red blood cells that was already producing too slow. And I had to be on this cyclosporin for quite some time, and they weaned me off of it though. And
Mm-hmm.
so far so good.
Thank
But there's
God.
just
Yeah.
it's like always, something else. But like I asked my doctors, like, how would I have ever have known that thymoma tumor was in there had I not gotten breast cancer?
Mm.
Who would know?
Yeah. Or maybe that thymoma wouldn't have necessarily developed or gotten aggressive or active without the chemotherapy.
Oh, maybe, right, and that's what
Yeah.
I was thinking too. That's
Yeah.
why when I was first getting, anemic, my
Mm-hmm.
oncologist thought it was an iron deficiency
Mm.
because she had
Well, that's
seen
the
that
most
happen
common.
with
Yeah.
yeah,
That's the most
and
common.
she had seen that happen with chemo and stuff like that, and it turned out to be a
Mm-hmm.
completely different type of
Yeah.
anemia. Like, I could do a whole TED Talk on it. I was gonna say that, people that learn from you, I feel like you give them enough information where they actually could go do a TED Talk. You know? I
Well, I
mean,
hope it's not overwhelming, but
no, I think it's important for people to know this. And so I want to go into next to
mm,
talking about winning the cancer journey.
mm,
How is that structured? How has
mhm.
that kind of changed over time since you and I first met?
So, as you know, your audience probably doesn't. I actually retired from Memorial Sloan Kettering in August, and that was a rough month or two, to be honest with you, because I left this job that I had been part of my life. It was my life for 25 years, right? So now I'm not going and seeing my patients every day, and we're not going to get into this today, but I had a medical issue, a chronic medical problem that contributed to my retiring, but I am still functional enough that I have still have so much to give and to teach that I needed to pivot and find another way to do this. And so I developed. Oh, let me just step back. So that same month, my last kid moved out from college to go to
Oh boy.
college. So I became an empty nester and what changed my whole career path. So that was a tough couple months. But winning the cancer journey, as I mentioned, I named it that because I want people to be the best get the best that they can out of their cancer care and their treatment to go through their journey. And the reason I use the word journey is because I don't feel like it really ends when the chemotherapy ends. You still are, the journey changes a little bit and the road will wind, but you're still always thinking about cancer and dealing with the fact that you had cancer, et cetera, et cetera. So, and, unfortunately some patients recur. And so the journey is never really over. So that's why, because I know some of my patients are not sure they like that word or not. So I'm thinking about rebranding, but at any rate, so what I love to do is to speak. I am very passionate about trying to get into some of the breast cancer organizations and be able to give some of my talks, both about mindset as well as about educating. And, if I'm speaking to caregivers about how to educate patients better. And I am actually in the process of writing 2 online courses, as you had mentioned. So,
Wonderful.
so one is specifically for caregivers and one is specifically for patients. And the reason I decided to do both is that I think they're both critically important.
Yes.
I often find that patients, when they're in the exam room with me, will not necessarily absorb everything that I've said, which is why I write things down and send them home with drawings and such. But I feel like if you had in your own time, in your own space, at your own pace, the ability to sort of understand and learn a lot of the concepts, for example, that I discussed tonight, I feel like that would be very, very helpful to patients.
Very helpful.
And then the caregiver course has a lot of that same education in it, but also talks about how to be a good caregiver, because a lot of times people that are the caregivers don't really know what to do. They don't know how to best help their loved one or their friend. And, I've being in the space for so long, I know how important it is to have the caregiver on board, sort of not just as like the support system, but also to be the advocate for the patient when the patient isn't, feeling well or isn't able to sort of ask the questions that they need to ask. And so I feel like it's really important to educate both sides. So.
For sure. Yeah.
Yeah.
No, I totally agree. My husband came with me to all of my appointments. It was very rare if he wasn't there. I don't even know if there was any time. He came with me to my infusions and all of that, but he took very, very detailed notes because I was just in a world of, and so when we would come home, I would take his notes and I would reformulate the verbiage and how I wanted to put it out there, because I had a caring bridge and I also had a Facebook private group. And that's how I would update all of my friends and family, is taking his notes. And then that helped me absorb what was going on in my own body. So yeah.
Sure. So you had a really good support system. You both
Not everybody does.
Not everybody does. And the other thing is that, sometimes depending on education levels, sometimes patient doesn't have somebody to go with them, what have you. So that's why I'm still offering second opinions and concierge work. And so, what that means is basically, and I'm not taking a lot of patients to do that, just handfuls of them, because I want to be able to take care of each of these patients like my own, just as opposed to in a clinic where I'm seeing 25 patients every day and I'm writing notes all night long and what have you. If I have a handful of patients that I can take exquisite care with, that I'm their doctor in the pocket, that they can call me on my cell phone and ask me, hey, my doctor just said XYZ, what does that mean? I can set up a Zoom call with them and go over the whole thing. And so I am still practicing in that manner. I'm just not prescribing anymore.
Okay.
I'm just doing virtual second opinions and what I call concierge work, meaning that I'm sort of helping guide patients through what they're going through and helping to interpret and explain to them everything that's going on, because not everybody's doctor is, adept at doing that or takes the time to do it and that kind of thing. So.
Yeah, I love it. You clearly, really love what you do, and you've helped so many people, and even online now. Tell us about your book. What is the book? What is the structure of that?
Sure. So thank you for asking that.
Yeah.
My book is my baby, and I am kicking it out the door by January 1st to get its next round of editing. Because I've been dreaming about writing this book for so long. This book it's currently, the working title is Winning the Cancer Journey, although that is still, I think I might send out a survey to my Facebook group, my private Facebook group, and see what people think about that name. At any rate, I have a couple of ideas. So I take this book, and the chronicity of it is that when a person is first diagnosed, meaning that the first time you hear like, oh, I feel a lump, oh, there's an x-ray that's abnormal, oh, now what's going on? Maybe it's cancer. And I walk you through the entire process, written from a physician's standpoint, speaking on a patient's level. So, there are chapters on radiology and the workup, the different type of biopsies that you can have, how to look at your pathology report, what is a receptor, as you can imagine. So, and right now it's 13 chapters. I am currently finishing up a chapter on mindset and another chapter on integrative medicine. So I am not an integrative medicine specialist, but it was one of the things that my patients most frequently asked me about. What supplements can I take? Can I get a vitamin C infusion? Do I have to take chemo? Can I get a coffee enema instead? And I'm not making light of it. I'm just saying that, like, I have heard it all. And I just want to try and address some of the more common questions that I've heard in the past. Again, I personally feel like there is a marriage that needs to be made between allopathic and functional / integrative medicine in terms of oncology. I come from an academic institution, and functional medicine is very much not looked at as real stuff. I think it's somewhere in between. And I do think that sometime in the, hopefully in the not so distant future, that the two will be more married, because I'm kind of off topic here, but I love the fact that functional medicine goes after the root cause of the disease. And I think until now, at least, a lot of our medicine is really just treating it after it happens, as opposed to figuring out how to prevent it.
I mean, trying to prevent inflammation in the body, that all goes together. So I've grown up in a family who has been very big into functional medicine. What is it that we can, eat or not eat that can help our body be at an alkaline level or whatever, low inflammation, checking your CRP and stuff. We actually have an integrative oncologist here in Reno, and one of my friends is seeing him. We're not just working with him, though. He is very much into working with a general oncologist, oncologist. So they're working as a team. And that to me, that spoke to me, because, he's not just saying, oh, no, you should just do this and everything should be fine and your cancer will go away. He's like, no, there is a place for me and there's a place for a general oncologist. Yeah. I like that.
I feel that, most of the medicine that I'm coming from, mainstream Cornell Medical School, major hospital systems, we're the closest that we get to going after the root cause of a cancer, sort of trying to prevent it, can be with, some of the immunotherapy approaches, some of the vaccine approaches, and then some of the specific drugs like a PARP inhibitor. I don't know if you've heard about those before, but PARP inhibitors are used in patients that have a BRCA mutation. And so those drugs are being used in patients after their treatment as a maintenance, for example, and helps prevent new cancers as well as recurrence of the same cancer for patients that are at high risk because of BRCA. But they're now looking at using those medicines as preventative as well. So if you have a BRCA gene, maybe you have to take this medicine for a couple of years to help prevent you from getting a breast cancer. But those types of things are still being looked at. So it's not standard yet.
You mentioned when we talked last week or whenever it was, that when you went to the breast cancer symposium, you went in a very different capacity than you used to go. So you used to go as a medical oncologist, and you still are, but in a different capacity.
Right.
How was that for you? What was that like?
It was very interesting. And in fact, I think in some ways it was much more fulfilling, because I'm doing different types of things. I'm doing a lot more advocacy type of work and public education and that sort of thing. I spent more time going and meeting the advocates and the volunteer groups that were there that are supporting these meetings. I was looking at spoke to different drug companies that I knew had different developments of things that were coming up because I wanted to be able to speak for them to my patients as well. So I wasn't necessarily just learning exactly what the new latest and greatest is of treating ER negative breast cancer. I did learn that, but I also was looking at it from more of an advocacy, patient education side of it as well. So
Fascinating.
it was very fulfilling. It really was. I was exhausted by the time I got home.
I knew
I
you would
slept
because
for like a day and a half.
yeah, I've heard that it was just really awesome. So
Yeah.
absolutely, when we can sign up for that, I will definitely go with you. We'll room together, we'll eat together, we'll have a good time together, learn from each other. Online, I have your Facebook page,
Mm-hmm.
your Instagram and your
Yep.
LinkedIn that people can follow.
Yep.
And I just really think that what you're doing is so you know, it's just much needed. Uh,
Mm-hmm.
because I really do believe that, well, not all oncologists actually educate their patients the way you do. And
Mm-hmm.
because you are out there and you've retired and you're still out there, though, advocating for others, willing to help them and actually help tell them what's going on in their body, why they're getting certain, medications. And then
Mm-hmm.
on top of that, you have a book. And
Yep.
I'm really looking forward to seeing, though, the courses for new
Mm-hmm.
patients, but also the caregivers. And
Mm-hmm.
caregivers are just as big of a part of it all,
Huge.
Yeah,
Yep.
yeah.
Exactly. So
Well, I
true.
think this has been great. I'm glad that you were able to share your
Yeah.
highlights from the symposium and what you're doing and your book that's coming out in January. I am curious what you're thinking about, renaming, what words you might be looking at for journey in place of journey. Because I know that people, like, I
Mm-hmm.
don't mind it. I don't care. I know what it is,
Mm-hmm.
I don't know why that word triggers people so much.
Mm.
Um, but I am curious what kind of name you would come up with.
So I was speaking to an advocate yesterday or 2 days ago, um, who you might know from what is it? The fashionista,
Yes,
breast
yes.
fashion. Yes, yes. Amazing, amazing woman. And
I just started listening to her podcast.
I'm actually going to be on her podcast next week. So,
Awesome.
yeah. But at any rate, so she and I were chatting about this, and she mentioned we talked about it because I had heard from somebody else. And it was like the second time I heard somebody say it. One person said they didn't like the word winning because once you have cancer, you never feel like you're winning. But, okay. And then some people don't like the word journey. So,
Mhm.
again, I think once I explain it to you and why I called it that, I think people would understand better. But I don't want to turn people off, obviously, from the get go if they don't know what I mean. So Melissa had actually suggested to me, because I want to give her credit, calming the cancer chaos.
Calming the cancer chaos. I love it.
What do you think?
I love
Pretty
it.
cool.
Slaying the cancer beast.
Killing the
Slaying, no, I like that too, but because it is chaos. And I mean, obviously, you want to calm it. And so I think that's really good. Yeah.
Interesting, right? Yeah, so I'm working with it. I'm using a little
Okay.
chat GPT, throwing words in there and let it spit it back to me, see what's there. And then, like I said, maybe I'll throw a survey into my private Facebook group. So
Absolutely. I think you should.
hopefully all your listeners join my group because it's a nice
Yes.
group.
Well, I will tag you on when I post about this
Mm.
as well.
Okay.
And yeah, I just always enjoy getting together with you and chatting about the important things. And I just want to know, do you have anything to leave us with before we disconnect?
Thank you for having me. I feel like it's like not only like a duty for me to share all of the information that I have, but I also feel very honored to be able to explain to everyone and hopefully make people's journey or pathway or walk through
Chaos?
their cancer chaos to make it easier for them. Like, I feel like it's almost a calling for me to do that. And so
Yeah.
I'm really happy to do that. But what I do want to say, the one piece of information I wanted to make sure I impart is that make sure that you're advocating for yourself, and make sure that you are always comfortable with the information that you're getting, the recommendations that you're getting. And if you're not, you need to ask more questions, get another opinion, make them explain it again, advocate for yourself. Don't be afraid to do that.
You know, what's really interesting is that when I first found out that I was getting chemo, someone in my family from the East Coast sent me a message and said, "Don't do chemo. It'll ruin your body. You need to call Sloan Kettering or Mayo Clinic." And so, had I called Sloan Kettering, I might have gotten you. We would have met on a totally different circumstances, right?
Well, listen, very possible, but
Yeah.
you couldn't fly from Reno to New
Like,
York
what
for
would I
treatment.
don't how would I do
Boy.
that? But anyway, everything worked out so far. So, all right. Well, thank you very much again. And I've learned so much from you, and I continue to learn from you, even into my survival journey. And so we will reconnect again and talk about some other things. And until then, thank you. I hope you have a great holiday. We are recording this. It is the 22nd of December. And so it's almost Christmas and New Year's and Hanukkah and all the things and Kwanzaa. So happy holidays to you, Dr. Troso, and to my audience. Thank you again for joining us. And I just really hope that you can go to YouTube. This video will be on YouTube. Dr. Troso was showing us a couple of things with her hands that you might want to see. And so if you go to YouTube, you'll see the video. And if you can go to all of your platforms, wherever you're listening, and rate and review, it really does help spread this podcast around the world. And until next time, we will see you on the next episode of Test Those Breasts. Bye for now.
Bye. Thanks.